Hello and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thanks for joining us. I'm Alan Card, your host for today's session. As a bit of an introduction, I'm a research associate with the Center for Health Design, where I've been working on several special projects, including the development of the CHD Online Safety Risk Assessment Toolkit. And I also serve as editor of the Journal of Healthcare Risk Management. I hold a PhD from the University of Cambridge and an MPH from the University of South Florida, as well as professional certifications in public health, healthcare quality, and healthcare risk management. My research interests include intervention design and evaluation, especially as applied to safety, quality, and risk in healthcare and public health. The purpose of the Evidence-Based Design Journal Club is to engage the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes and apply that understanding to the real world. I'm now excited to introduce you to the author of the article we're discussing today, Dr. Sarah Bayramzadeh. Dr. Sarah Bayramzadeh is a research assistant professor in the Architecture and Health program at Clemson University. Her research interests include the impact of healthcare facilities design on user experience, patient safety in psychiatric units, health communication, and operational efficiencies. In her role, she contributes to several research projects at the Center for Health Facilities Design and Testing, including a project on safety and efficiency of operating rooms. She obtained her doctorate in the interdisciplinary program of design, construction, and planning from the University of Florida. Her award-winning dissertation explored the role of the interior environment and the role of the interior environment in the physical and psychological safety of psychiatric patients who are one of the most vulnerable patient populations. Thanks so much for joining us today, Sarah.
Thank you very much, Alan.
As I mentioned, we are hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured article, an assessment of the levels of safety in psychiatric units from the Health Environments Research and Design Journal. On today's call, we'll have an active discussion about different key factors in your study. Could you please start us off by giving an overview of the problem space and the questions you're trying to answer with the study?
Sure. The purpose of this study was to evaluate conceptual frameworks that Mr. Hunt and Frank had developed on levels of safety in psychiatric units. As you know, there isn't much about the design of psychiatric facilities out there. So this conceptual framework was one of the things that is referenced in many of the design guidelines and is based for many design practices. Although there wasn't any evidence supporting this conceptual framework, and the purpose of this study was to validate the levels of safety in psychiatric facilities. So with that, I'm going to start the presentation. I'm sure many of you are familiar with mental disorders. There are a wide range of different disorders, including schizophrenia, depression, PTSD, anxiety disorder, panic disorder, and so on. There is a stigma behind this. Many of these disorders, unfortunately, and many people do not seek help for that. But for the people that do seek help, we have the number almost 26% of people in the U.S. Suffer from a sort of mental disorder every year. So this number can be higher in reality, but this is what evidence shows. So psychiatric patients are one of the most vulnerable patient populations, and there are a number of safety threats that they experience. One of them is threat to self, and the other is threat to others. And the category of threat to self includes any type of self-harm efforts that they might try, or also suicide. Now, in terms of threat to self, there were a number of more than 150,000 people were hospitalized in 2007 for self-injuries. And in 2015, more than 800,000 patients were treated in emergency departments for self-injury. The other type of self-injury that I mentioned was suicide. Suicide is an attempt to take one's life away, and patients with depression, schizophrenia, and drug dependency are at most risk for suicide. In terms of numbers, what I'm presenting here is about healthcare facilities because patients with mental disorders seek help, especially in a hospital, to be sure that they're in a safe place, or the people that take care of these patients want to ensure that healthcare facilities are a safe place for them to allow them to heal and go through the treatment that they need to. But unfortunately, about 1,500 suicides occur in the healthcare facilities every year, and a third of them happen between 15-minute rounds or even on one-on-one observations. I think I need to mention what 15-minute rounds are. Usually in a hospital, the staff members are required to check on patients every 15 minutes. And in a psychiatric facility, the staff members need to be sure that the patient is breathing fine, their chest is rising, so they really need to closely observe the patient. But within the time frame that is left between the observations, patients might commit suicide.
In this one-on-one observation, somebody just literally sitting there with the patient then?
Yes, unfortunately that is possible too, just because the nature of mental disorders, because of that patient, some patients might have unexpected behaviors, and it is not really predicted by the staff member. If I want to give you an example, in the narrative that I read from the hospital, a staff member was sitting with one patient, and the patient suddenly jumped in the floor just because of the hallucination that he was experiencing, encouraging him to do so. So that's just one example of self-harm, but due to unexpected behaviors, that is possible. The other type of safety concern is falls, and falls is a very common safety concern among all patient populations, including psychiatric patients. The number of falls for patients in psychiatric facilities is also high, and some of those are associated with the medications that they take. Some of the side effects of medications include dizziness or even seizure. Before moving on, I mentioned that the patient population in mental disorder area is very vulnerable, and the reason for that is these patients do not usually have insight towards their disorders. So, for example, a patient with schizophrenia may not have any insight that he or she is suffering from that disorder, and it is up to other people around them to take care of themselves. But in an example of somebody having a cold, they are aware that they're suffering from a disorder, and not disorder necessarily, but a disease, and they can take care of themselves. But what makes this population vulnerable is that they do not have this insight. Now, the objective of this study was to validate the levels of safety. I'm going to just explain what are these levels. So the conceptual framework proposed by Mr. Hunt and Fine is divided to 5 different categories. And these are based on the level of safety that is required and because of the interaction of patients with the environment and people around them in those areas. Level 1 refers to staff service areas, and patients are not allowed in those areas. Level 2 is the hallways or corridors, and patients do not necessarily spend a lot of time there, but that's the place that they're exposed to everyone, and they walk around. Level 3 refers to day room or a lounge space that patients are encouraged to spend time in there, and that is, the purpose of this space is to do activities and interact with other patients. Now, as opposed to other patient populations, patients in psychiatric facilities are encouraged not to spend time in the room, but to spend time in the day room with other patients and staff members. Level 4 refers to patient rooms and bathrooms, and that's where patients get to spend a lot of time being alone and not necessarily supervised. Level 5 is divided to 2 different spaces. One is the admission or intake area where the patients are admitted and evaluated for being hospitalized. And the other type of category under level 5 is seclusion room. Seclusion room is a place that is designed to be safe, and patients with extreme conditions are placed there to go through the extreme episode that they have.
And could you tell us a bit more about how you went about trying to answer this question?
Sure. I used 2 different methods to go about these questions. One was gaining some retrospective data from the hospital and conducting some focus groups. I worked with a psychiatric hospital in the southeast of the U.S., and they were able to share 7 years of data with me about patient incident reports, and they were in form of narratives that explained every single incident with details of what actually happened. I had to go through all of that. I was able to have about 2,500 incidents in form of narratives, but location was not necessarily mentioned for all these incidents just because it wasn't one of the information that they would collect. But depending on the description of the incident, I was able to pull the information about the location. So because of that limitation, the number of incidents that I was able to analyze went down to about 1,300 incidents. And I also conducted some focus groups with the staff members that I will be talking about.
And why those specific 7 years, 2007 through 13?
The hospital was willing to share with me all the available data that they had that might be associated with the environment. And they had started collecting electronic data from 2007. And fortunately for me, I was able to have all the data from 2007 to 2013 when I conducted this study.
Must have been fun coding all of that.
Very much. So like I said, this was a psychiatric hospital in southeastern part of the U.S. It was about 27 years old, and it had a total of 81 beds with 4 different units of substance abuse unit, child and adolescent, geriatric, and adult psychiatry. There were more than 150 staff members working in this facility. I have an example of one of the floor plans for you here. All 4 units were very similar in terms of the setting for patient rooms and corridors and the day room. In total for the hospital, there were 38 single rooms and 19 double rooms shared in all the 4 units across all the units. And average length of stay for patients were about 6 to 11 days, with adult psychiatry having longer days compared to other units. So this floor plan shows very quickly where are the different levels located. The pink area or purple area is the corridors, and you can see the entry and exit at both sides of the corridor areas. After entering the unit, they go to a corridor, which is not too long, and then they enter an open space within which you will see a green space. That green space is open. It's used as a day room. And the way the space is defined is through the arrangement of furniture. The lighter green shows the staff service area, and that includes nurses station. And in this particular hospital, the nurses were able to have a good view from the nurses' station to the day room and some of the bedrooms. The bedrooms are all the darker green areas around the pink corridor-related areas. And the good thing about that was staff members were easily able to see the doors of the room, which is very helpful to just know where everybody is, which is very important in the psychiatric facility. Everybody needs to know where all the patients are to ensure that they're safe, they're not missing, or also the staff members are known where they are located. The larger gray areas you see at the bottom, they are courtyards that patients were able to use.
And the patients' restrooms, were they in the patients' rooms or in the hallway?
Yes. Patient rooms had their own private patient bathrooms, so they were inside the room.
Thank you.
Good question. So the data that the hospital shared with me were categorized in different types of incidents, and they included contraband, which means basically any object or small object that patients may use to harm themselves or use out as a weapon, potential weapon to harm others. Elopement, let me just give you some examples of contraband that can include a pen, just a simple pen, or even a bed sheet. If it's too long, they could use that for hanging themselves, or a cigarette or some sort of drug or medication that they're not supposed to use. Elopement refers to escaping from the hospital in simple words. In many psychiatric facilities, depending on the system that they have, they keep the units locked. So the patients are not allowed to exit the unit without approval of a staff member or healthcare provider. So any unauthorized exit from the unit is called elopement. And that's for patient protection because they're vulnerable when they go out. They basically do not have any of their belongings when they exit the unit because they're kept at the hospital. The other category is fall, which you can see is the highest number of incidents. Improper behavior is another category that refers to a wide range of behaviors, including self-harm or any sexual behavior that is not supposed to happen in the unit. We have the category of suicide and violence, which can be towards someone else or not necessarily someone else, but behaviors such as throwing objects or punching the wall are some of the examples. The category of other refers to any other incidents that are not in these categories, and that may include confidentiality issues or lost and found if patients claim that some of their belongings are missing.
And I'm sorry, I may have missed it. Did you say where the self-harm other than suicide fit in there?
Self-harm would be under the category of improper behavior, just because they're not supposed. It's not considered a safe behavior. Improper behavior is, like I said, it's a very wide range of behaviors, and it's one of those categories that may include a lot of incidents in it. So here I'm going to show you how each incident is compared to the total number of incidents across all levels and how that is consistent with the levels of safety that is proposed by Mr. Hankenstein. So as you can see, the total is the light gray on top, and that is consistent with what the prediction of the levels of safety proposes. For patients' rooms and bathrooms, it has the highest number of incidents. For day room, it's the second highest place to host incidents, followed by corridors and intake area and seclusion, and lastly, staff area. Now, for incidents related to contraband, as you can see, the patient rooms are again higher than any other categories, and overall, the pattern for contraband is consistent with what the prediction of the levels of safety is. For staff area, we have 0 incidents there. For seclusion, we also have 0, which is a good thing because seclusion is supposed to be a safe area for patients to prevent any sort of unexpected incidents within it, just because patient is in extreme condition and they need to be somewhere that is safe and would not harm the patient. For elopement incidents, the patterns are not consistent with what the predictions are, and they have the highest number of incidents in corridor. And thinking about that, it makes sense because the exits and entrances are located in the corridors, and that's where the patients can elope from the unit. Usually when a number of people are entering or exiting the unit, that's a good time for patients to blend in with the group and exit from the unit. In regards to falls, it is, for the most part, consistent with the prediction of the levels of safety. However, there is one incident in the staff area which is not expected just because patients are not allowed in the staff area. As you can see, patient rooms is the rooms and bathrooms. They can have the highest number of incidents.
And I'm sorry, why do you think it is that they have the highest number of falls in the patient rooms and bathrooms?
Good question. So usually most of the falls would happen also during the day, but also during the night. Patients would wake up in the middle of the night and they want to go to the bathroom, for example. Usually the room is dark and patients do not turn on the lights, mostly because in this particular facility the light switch was placed near the door, and the patients usually refuse to go back to the door to turn it on and then go to the bathroom. So because of the darkness of the room, they bump into things or trip over something and they fall. Also, some of the falls happen in the bathroom, and sleepiness of the patient is another factor contributing to that. Now, not in the middle of the night. Another example can be when the patient is ready to go to bed, and they enter the room, they turn off the light, and then they proceed to go to the bed. And again, just because the room is dark, they usually trip over something or they bump into the bed. These are some of the examples of having that number of falls higher in patient rooms. Also, the visibility of staff is lower in patient rooms compared to when they are in the day room, for example. So that lack of direct help can be an issue, although patients that are, with higher fall risk, they do have constant monitoring, but not necessarily all the patients. Improper behavior was partially consistent with the levels of safety, and for the most part, it was consistent, except for the staff area, where, again, we had 2 examples of incidents. Suicide was consistent with the prediction of the levels of safety, and it had the highest number of incidents in patient rooms, which out of 10, 9 of them happened in patient rooms or bathrooms. And that explains itself that this is a private area for patients on the unit, and that's where they have, the opportunity to commit suicide or try that. Another example that happened was in the intake area. Intake area is where patients are admitted and they will be evaluated to be hospitalized. So that's where there's a level of unexpected issues or behaviors that cannot be predicted. So it is important to keep the intake area as safe as possible too, just because there are a lot of patients entering from intake basically to the hospital. So a number of diagnoses or levels of severity of the disorder can enter, and that's important to keep the intake area as safe as possible.
Absolutely.
Now,
just one quick question about that one.
Sure.
I'm sorry. The suicide there, is that successful suicide? I hate to use the term successful, but attempted suicide or actual suicide, or both?
That's a good question. So the category of suicide actually includes both of them together. So any efforts to commit suicide or any successful suicide.
Thank you.
So across 7 years, it was 10. It might not, compared to other incidents, it's not that high, but actually 10 people thinking about that, it's actually a high number. Even one is higher, there shouldn't be any suicide happening. So violence was not consistent with the levels of safety. It was mostly happening in the day room and followed by patient rooms and bathrooms and corridors. The reason for this might be because in the day room, patients get to spend a lot of time with other patients and staff members. That's where they have a lot of interaction with others. And violence by nature happens a lot with when there is an interaction with other people. Although, like I said before, it may not really involve other people. It might be punching on the wall, which was an example in this psychiatric hospital. But day room makes sense to have most of the violent behaviors within it, just because of the interaction with other patients.
And speaking of the day room, one of our listeners was asking in the chat area, is that the same thing as the dining room for this facility? No, not necessarily. The day room, also called activity room, that's where patients gather for the day. Any type of activity can happen there. Patients in psychiatric facilities do not spend a lot of time in their room. They're discouraged spending a lot of time in their room. This is, again, not similar to what other patient populations experience in a hospital. They usually stay at their rooms, and that's where they get treated. But for psychiatric facilities, patients are encouraged to spend time with others, involved in activities, and try to have that healing process with others. And a somewhat related question is, were those, remember the exterior courtyards you showed, were those included in this analysis at all?
The courtyards, no, just because it wasn't part of the levels of safety. It wasn't one of the categories in there, so I did not include that in the analysis.
Thank you.
You're welcome. So only looking at each level and seeing how the patterns of incidents are different. This is an image of a staff nurses station. As you can see, there are windows there that they can see the rest of the unit, the corridors, and day room. So for the staff service areas where patients are not allowed, we still had a number of incidents happening, and the highest one was violence, followed by improper behavior. Violence makes sense in this area just because patients are not allowed there, and there is a possibility that the only entry to the staff service area would be would involve some sort of violent behavior. For level 2 incidents, referring to corridors, violence was the highest, followed by falls and elopement. Again, violence is the highest in this particular level, probably because they are exposed to other patients, and also compared to other types of incidents, that would be a very common one. Fall is the next one. Usually patients, as they're walking, if it's a medication side effect, they can have a seizure or dizziness. But in terms of environment, one of the interesting things that kept repeating in the narrative was that patients use corridors as a place to run. As you know by now, the patients do not necessarily need to stay in bed to go through the healing process, but they walk around, they talk, they interact with others, and they do get bored in facilities like that, especially because it's locked. They don't really have many options as to how to entertain themselves, or very limited choices on what they can do. So if a facility doesn't offer space to patients to spend time entertaining themselves in a healthy way, they probably end up running in the corridor if they want to. And so many of the falls happen that way, just bumping into one another or not having really a space that is intended to accommodate for running. So it is not the safest place to be utilized for that. In level 3, which is the activity rooms, as you can see, this is kind of a multi-purpose room. So this is where patients eat, play, read books, or meet with one another. Falls were the highest in this level, followed by violence and improper behavior. So we talked about violence before, that again, that's where patients are all together doing activities. So there's a possibility of violent behaviors happening. Now, category of falls by this hospital was divided to so many subcategories, including fall from chair, which happened a lot in the day room for some reason. This was not necessarily the built environment, but it included furniture, which can be part of the environment design. In rooms and bathrooms, falls were the highest type of incidents, followed by contraband and improper behavior. So I mentioned some examples of falls in the bedrooms, which happens when the room is dark. And the second type of incident is contraband, where again the patient rooms are the most private place that patients have on the unit, and that's where they get to hide some of their belongings. Or if they have a visitor over in the bedroom, that's where they get to exchange things if the visitor is not a very helpful support to the patient's healing process. This especially happens in the addiction unit, with drug dependency. For admission and intake.
I'm sorry to interrupt. On the previous slide, I remember in your paper you mentioned that they had moved in some of the rooms to a special kind of door to the bathroom that allowed the nurses more visibility into at least the presence of the patient in there while maintaining some privacy. Could you tell us what those were like?
Sure. This image actually shows an example of that. This door is a partial door. So at the bottom, you actually have a view, and the staff member is able to see, the patient, not the patient, but the legs or feet, and that gives them a sense of how the patient is or what they're doing, or is everything okay. The door is also slanted on top section of that, you can see, and that's a very simple design solution that prevents suicide efforts. If the patient tries to hang anything from here, it would just slide down. So this is a very creative solution to protect patients from suicide efforts or self-harm, and also enables staff members to have some level of visibility to patients and being able to monitor them.
Thank you.
You're welcome. So in intake areas, other types of incidents, which is mostly confidentiality related, happening in the intake. Although this is not a safety threat to the patient, but that's something that can be addressed through the built environment, providing spaces that are more protective of patients' privacy and confidentiality. Violence was the second type of incident, and just because, again, patients are not known for the status of their disorder, incidents such as this can happen, or resistance to entering the hospital. Seclusion, I'm sure you're familiar with it, but they are rooms that are extremely safe in terms of the built environment. The patient is not able to harm themselves. The walls are padded. Everything is very safe, no sharp edges. And the reason for that is because patients with extreme conditions are to place in these areas. So as they are going through that, they won't be injured necessarily. Now, as you can see, violence is the highest number of incidents, and this might be because the patients, as they're entering the room, they're still showing some violence-related behavior. But other than that, suicide, elopement, contraband, and improper behavior are not something that necessarily happen in these areas. In terms of patient type and incident reports, I thought this would give everyone a better idea of what type of patients would have different threats to themselves. So if schizophrenia and psychosis, they include a lot of violence-related behaviors and also suicide and falls. Patients with dependency on drugs or alcohol experience a lot of contraband and falls. So contraband, again, it can be exchange of any unauthorized medication or some sort of drug that they're dependent on, and they can receive those from visitors, or they can hide them somewhere in the room. Patients with depression experience suicidal thoughts, and there's also a contraband issue with these patients that are usually used mostly expected for suicide efforts. Patients with mood disorder experience violence and falls and suicide. So as you can see, 3 of these categories that have highest number of incidents include suicide, psychosis, depression, and mood disorder.
This looks like a really rich data source that you're pulling from there. Did you run across any limitations in being able to use it?
Actually, yes. The data offered a lot of good insight, but there were some major limitations with that. The way data was collected did not really provide all the variables that are related to the built environment. So for a researcher like myself that is interested in the role of the built environment, it was challenging to pull data from what existed. So for example, for the location, I had to go through all the incidents in hopes of finding out where each incident had happened. So depending on the details provided by the staff members when recording the incident, I was able to get those information that I needed. The other limitation with that was just because I did not design for that, and the nature of retrospective data is like that. I do not necessarily have the data that I can control for. If I want to have some sort of statistical analysis, I may need to control for some variables, but when they are not collected, I do not have any ability to conduct some of the analysis I would like to. And the design of the study would be limited very much to the data that exists. The other limitation with the data was because it was over the course of 7 years, it was very obvious that narratives were recorded by different staff. Although they are trained to enter similar details for each incident, but the way they've been written or the level of details they provided, they varied greatly, and that was another limitation of not having that consistency across all the narratives that I was reading. An example of that was very obvious for seclusion room. That's a tricky one because patients that are placed there are experiencing violent behaviors. So for some of the incidents, I felt that the staff member recording that incident was not sure to count that as a violent behavior or not. Because by nature, the patient is violent, so that's why they're going to the seclusion room. But being in the seclusion room does not necessarily mean that was a violent incident, if that makes sense. So in terms of gender differences, the numbers show that there isn't really much difference between men and women in terms of different types of incidents. Especially, I think for violence, there's this thought that probably male patients are way more violent than female, but the difference looks to be not that large. So I was able to have 9 staff members to be in the focus group split, and they provided some good insight and tangible examples of what was happening as they conduct their everyday job. So one thing that was a concern was when the patients are in the bathroom. One of the nurses mentioned that it's really bothering them when they're not able to know how the patient is. They're not able to hear them. The nurse was indicating that he would go near the door and try to talk to the patient, just to ensure that the patient is okay. The other feedback that they gave me was about nurses' station and the view that they had to the day room and also some of the patient rooms. And that was very positive to be able to see them without necessarily have to, go out of the nurse's station to find where the patient is in the day room.
And speaking of the patients, why no patients on the focus group?
I'm sorry?
And why weren't you able to include patients in the focus group?
Unfortunately not. Unfortunately, access to patients was very difficult just because of the confidentiality and some of the other sensitive issues with patients with mental disorders. The other feedback that I got that discouraged me from being in direct touch with patients was the reliability of data that I will gather. Because depending on the disorder, the feedback that I could gather, the accuracy of that would have been questionable. Although with some other patients, it would have been fine, but because of that limitation, I did not pursue that. And I chose staff members just because they are in direct care with patients every day, and they have a lot of experience dealing with different patients, which enables them to know the experiences and what are the expected behaviors. Okay, so in conclusion, the data that I gathered from this specific hospital supported the the assumption that the levels of safety proposes. So the order would be, again, staff service areas, corridors, day rooms, and patient rooms. But according to the information that I got, I would suggest that seclusion room would be the second level and followed by admission area. Admission area is actually one of those that many incidents can happen there, and it's not only about the things that happen inside that, but also when the patient is entered to the facility. So that's another challenge, having that place near where the ambulance is or where patients, caretakers are with them entering the patients in the facility.
And why is it that you think that the two level 5 ones from Hunt and Science framework, the admissions area and the seclusion room, didn't appear to be as risky in your empirical data set as they did in their framework? Is it just because, although those are risky spaces, they had better controls for those risks in place, or was there something else about those areas that made them less risky than they were initially supposed to be?
Yeah, I think what you said is exactly what I would answer. Yes, the seclusion rooms are designed to be a safe place, so we do not necessarily, there is a level of safety that has to be maintained for seclusion rooms, but seclusion room is one of those spaces that is very well known to require a higher level of safety. But for a space such as patient rooms and day rooms, there isn't really much out there to know which one should be a priority in terms of providing safety for them. So some of the design implications, of course, there would be a lot of implications. I think the main message that I would like to express is that it is important to know what are the priorities in a psychiatric unit. What spaces have to be first or, most important in terms of securing patients there. Knowing that patient rooms and bathrooms are one of those areas that have the greatest opportunity for safety incidents, that informs designers and architects to be aware of designing a place that is safer. That includes anti-ligature features for the furniture and the built environment, safeguarding the environment, and also providing visibility and accessibility to staff for better supervision of patients. Staff areas were not supposed to have any incidents in them just because patients were not allowed, but just because patients are not allowed, that doesn't make it a safe place, and some safety measures should be considered for those spaces as well. And since most of the elopements happen in the corridors, it is important to provide enough visibility for staff to be able to monitor the people that are entering the unit or exiting from the unit, and being able to see the patients at all times, so including the corridor and at the exit area. So as I mentioned before, the intake area is one of those sensitive areas that patients' status is not known, and that's something that was explained in the levels of safety framework as well. And the data actually supports that patients are not really evaluated prior to going to the hospital, and that risk of not knowing where the patient is can be very important in terms of providing safe measures for that environment. So there were some limitations with the study, and one of them was just the fact that the data was from 2007 to 2013. so many things could have changed during this time frame. For example, the medications or policies or any procedures that the hospital system had in place that could have influenced the type of outcomes that would show in the data. And also, it could introduce some confounding variables, such as different number of beds over time and how that influences the number of incidents. The other limitation that we talked about was lack of having direct access to patients, and I think future research should really try to make that connection with patients and get that direct feedback.
And a question from one of our listeners earlier on, I knew the limitation section was coming, so I held it for now. Was this hospital in a rural area or an urban area? Do you think that might have had any influence on the outcomes?
It was in a suburb area. It was one of the major hospitals around that area, so many of the patients from the surrounding towns would come to this particular hospital for treatment. I think just the opportunity to serve a wide range of people in that area opened us to a diversity among patients in terms of diagnosis or backgrounds of financial or otherwise. So that probably provided some, again, variables that were not accounted for. I did not have any information on what is the background of the patient or including, again, financial status, family size, or where they live, or all those things that can impact the severity of the patient's status, or giving some information on how they ended up where they are.
And to clarify about the data that you were drawing from, another questioner asked, did you have any control on the metrics that were used for the existing data? I've been talking about the categories of incidents and things like that.
Unfortunately not. Like I said, the data was gathered by the hospital, so I did not have any control over the categories of incidents they collected, or even the type of categories that they had. So I followed what the hospital had gathered rather than trying to create my own metrics. Just wanted to keep that consistency for the data that was gathered. Yeah, that was a huge limitation, actually, not being able to control for that.
Thank you. And before we move on to the Q&A session, I'd like to make a couple of brief announcements. This event is brought to you by the Center for Health Design. Thanks to the HERD Journal for providing free access to the articles we typically review, including this one. If you've not already done so, we recommend subscribing to HERD. There's a discount code to receive 10% off subscription. And special thanks to today's sponsor, Steelcase Health. For those that are currently designing a behavioral health facility, join us in Arlington on September 26th for an interactive collaborative problem-solving workshop intended to enable design professionals to employ physical design strategies and methodologies to improve care for behavioral health. Register by August 15th and save using code EDATTEND. EDAC and AIA credits are available. Again, if you'd like to earn continuing education credits for this session, download the form in the media library. For credit from the AIA, you need to purchase a CEU management fee, complete the CEU verification form and quiz, and email it to Catherine and Chetta. And now we'll move on to the Q&A session. We do already have a couple of interesting questions that came up during the course of the presentation that didn't really fit into the weave of it. And a number of them were focused on the aesthetics of the building itself, whether it's a representative of most design in mental health care facilities. They found it very dull and uninspiring. And access to views of nature. I mean, we know that they did have those two courtyards. I don't know what the environment was like out there. I know that's beyond the scope of what you were actually looking at in the study, which was validating the framework. But if you could just give us a little bit more background on those design features that would be helpful.
Sure. Yes, that was not necessarily in the scope of this particular article, but I am happy to share some background on that. Unfortunately, just because these units mostly are locked, that implies a sense of being in a prison, and the institutional look of the unit doesn't really help with that. Lack of access to outside limits patients to have only views from the window, possibly, or if in a hospital like this, if they're lucky enough to have a courtyard, that can really help. One of the other examples in terms of aesthetics is that in this, in one of the units in this hospital, they gave me an example of having a white wall that a patient kept punching, and then they painted that wall, and after that, the patient stopped punching that wall, which was very interesting.
Wow.
Yeah, it was very interesting. So there are things like this that can help. In the image that I showed you from the nurses station, there were some inspiring quotes that were on the wall, and patients actually very much appreciate that. The staff members also told me that they had recently provided some artwork in patient rooms, and they received a lot of positive feedback from patients.
Great. And I know that in a lot of cases, one of the things we run across in this patient safety area is that the only real source of data we have is incident reports, like the ones you were drawing from. But we also know that not all incidents actually get reported, and there are probably differences in the incidents that do and don't get reported, things that are easier to detect, things that are harder to detect, stuff like that, things that people feel are more important or less important. Do you have any reflections on the limitations of just using that as a data source? And, of course, the benefits as well.
Yeah, I can see that as more of a limitation. I hear a lot that there are a lot of incidents, not a lot, but a number of incidents that don't get really reported. I think that's really a limitation with retrospective data as well. But that's just something that happens, and it's not really in control of any researcher, I think. Did I answer your question?
I think so, yeah. I mean, it's just a challenge, you know. You don't have control over what gets reported, so.
Yes.
Any other questions for our audience? We are coming to the top of the hour. We've got one response to your story of saying, wow, that white wall story is great to hear. That's what I want to hear more about. Thanks for sharing. Do you have any other neat anecdotes like that you'd like to share?
Well, not necessarily the positive ones, but it's very important in the psychiatric facility to be careful with the type of artwork or the colors being used. There were some examples of having some sort of a circle type thing on the floor being perceived as a hole for some patients. So there are positive things that we can do, but there are also things that are with good intentions but may not be necessarily helpful to the patient. Depending on the patient populations, and although there are some units with some limitations in terms of access, I was in a unit that the staff members were able to take a group of patients downstairs in the wider yard that they had. Well, this example actually belongs to a unit within the hospital, which is a very different story than having a psychiatric hospital. The patients within a hospital are actually more limited than patients in a psychiatric hospital. So that was another thing that actually staff members gave me feedback on. Is they do prefer to keep patients separate than a hospital mixed with other patient populations, just because the nature of the disorder is very different, and they require different things than other patient populations.
Okay, thank you for that, and thank you so much for sharing your important work with us today. Thanks also to all of our listeners
Thank
for
you.
tuning in, and we'll see you next time on the Evidence-Based Design Journal Club.
Thank you.